Hello, everyone, and a warm welcome to today's edition of Patcast. Today is August 16th, 2022, and I'm Rifat Mandan from California, and I'm remotely joined by my good friend Emilio Madrigal, who is in Boston. Today, we are very delighted to welcome to talk with us Dr. Theonia Boyd, who is professor of pathology and immunology at Baylor College of Medicine, and she is also the surgical pathology director at Texas Children's Hospital. So today she's going to give a talk on obstetric pathology or pediatric pathology, and the title of her talk is Markers of Intrauterine Stress, Meconium and Nucleated Red Blood Cells. And thank you, Dr. Boyd, for joining us today. And as most of our viewers might be knowing already, that today's talk is accredited for CME by City of Hope. So let me quickly tell you about how to get the CME credit. And this is the screen that you can see. So, first requirement is that you have to create an account at City of Hope. So, if you have not done so, please create an account at City of Hope CME site. And I will share the CME code towards the end of the lecture. And then if you are joining from United States, then you can actually text the CME code to this phone number. And if you're an international attendee, so you can email the CME code to this email address, that is cme@coas.org. And you will also get a feedback form after that. So you will have to just quickly answer that feedback form. So with that, I would hand over the microphone to Dr. Boyd now. So over to you, Dr. Boyd.
Good morning, good afternoon, and good evening, everyone, wherever you may be in the world. In the moment, I happen to be on East Coast time. I'm in the middle of the woods. This is not a background screen. On Martha's Vineyard, which is a small island off the southern tip of Massachusetts. And I'm outside because it's the most peaceful place to be. So as Dr. Manan said, I was asked to give this particular topic, a lecture on this topic, and I'm happy to do so because I think about it, write about it, talk about it a fair amount. I will start by saying that before the lecture begins, the way I will talk about meconium and NRBCs is highly informed by the decades I've spent doing medical legal malpractice reviews as an expert witness, where the elements are, general elements in contention are standard of care and causation. And since most of these involve clinical practitioners, I don't discuss standard of care, it's rather causation. That is, what factor or factors were present, might have been present in the intrauterine environment that may have contributed to or caused a particular outcome. Since most of the cases I get asked to review are obstetric, and most of those revolve around unexpected, untoward outcome of pregnancy. So with that, I believe I'm going to try to stop sharing my screen and begin the lecture. Okay. First of all, I do not have any relevant disclosures, and this presentation and/or comments will provide a balanced, non-promotional, and evidence-based approach to all diagnostic, therapeutic, and/or research-related content. This particular slide was provided for me, but indeed I do adhere to all of this. Cultural linguistic competency and implicit bias. The state law of California reads as such. The California legislature has passed Assembly Bill AB 1195, which states that as of July 1st, 2006, all Category 1 CME activities that relate to patient care must include a cultural diversity linguistics component. It has also passed AB 241, which states that as of January 1, 2022, all continuing education courses for a physician and surgeon must contain curriculum that includes specified instruction in the understanding of implicit bias in medical treatment. And the cultural linguistic competency and implicit bias definitions reiterate how patients' diverse backgrounds may impact their access to care. The following components will be addressed in this presentation. The lecture will address different diagnostic approaches across different and culturally diverse patient populations, and the lecture will address how new classification can be applied to the populations in resource-poor regions. Well, I will say with respect to my presentation that it is culturally blind insofar as I'm talking about general features of intrauterine stress, regardless of place, time, or person. So I'll begin by telling you where I've been for the last 2 years. It's not been in this building, but this is a photograph of Herman Hospital, which was the first hospital erected in the site of what would become the future Texas Medical Center campus. And this was taken about 1925. I've been at Texas Children's Hospital as the division chief of anatomic pathology for almost 2 years now. So this is my home base, but it looks more like this today. This is the very same area where all of the buildings in the foreground are the Texas Medical Center, and the skyline that you see in the center background is actually downtown Houston. So Texas Medical Center is embodied in a 2.1 square mile radius. There are 61 institutions, 4 medical schools, and about 10 million patient visits per year. And indeed, we are the largest children's hospital in the United States of America by far. Okay, on to the topic of the lecture, placental evaluation and markers of intrauterine stress. So when there are markers of intrauterine stress as reflected in the placenta, because most of this talk will be geared toward placental evaluation, there is a release, a lag time in the response to stress once the fetal body senses that stimulus of being taken away from a place of equilibrium, that is a deviation from ideal equilibrium, which by definition imparts stress upon the fetus. And the lag time for NRBCs, I believe, is about an hour. So for example, if there were a pregnant mom driving a vehicle and she were involved in a collision and her pregnant abdomen were to hit the steering wheel and result in a complete abruption, even if the fetus were delivered emergently 30 minutes later without signs of life because it was a complete placental abruption, there would be no nucleated red cells released into the placental circulation, that is the fetal compartment of the placental circulation, because not enough time had elapsed between the onset of the catastrophic event and fetal death in order to allow that release to occur. Quick release, that is the release that occurs on the order of hours time, is mediated by adrenal hormones. And this is in contradistinction to the lore that is historic that says that release of NRBCs must be mediated through erythropoietin triggered erythropoiesis. That is a separate mechanism and one that does indeed take longer to put into effect. With meconium, the interval between the onset of the stress and release, it also shows a lag time, but one that is not well defined. I would say it's likely on the order of some hours of time, not otherwise specified. And in terms of the timing of intrauterine stress, this is what I think about when I think about placental evaluation in the context of untoward outcome, whether it's a stillbirth or a live birth with unexpected morbidity and or mortality. When did the stress begin? How long did it last before delivery and demise? And is there some sort of indirect assessment of stress severity? And I will just say that all of those factors conceptually are combined in looking at a moment in time screenshot of placental evaluation of your standard microscopic placental section slides. That is that the number of NRBCs that one would see, for example, is a combination of how long the stress had been operative, how long and or how severe it was. And there's no way to compartmentalize those so that it's a conceptual idea. There's no way to parse chronicity or severity. With mechanisms of intrauterine stress that may lead to release of meconium and or NRBCs, the strongest stimulus is hypoxia. And when I then have in parentheses that placental measures of hypoxia are stronger impetuses or stimuli than uterine and fetal, I mean it thusly. So for placental hypoxia, what I could mean is my former example of a complete placental abruption that would impart immediate anoxia. Uterine hypoxia would be, for example, a mom who is in labor and goes into shock. So let's say she's septic and goes into septic shock. That is a uterine mechanism of altered placental, maternal to placental blood flow and therefore deliverance of oxygen. And fetal mechanisms of hypoxia are probably the least common. And are conditions like congestive heart failure in the setting of either a congenital heart defect or some mechanism that leads to congestive heart failure in utero, like a 10-centimeter placental chorangioma that acts like a co-twin that the fetus must perfuse. Infection is the second most common and most robust stimulus of NRBCs and or meconium, and ascending infection, as we know, is much, much more common in the setting of pregnancy than is hematogenous infection. Metabolic is the least of the three common mechanisms that can incite hypoxia and or stress by virtue of strictly metabolic conditions. So, abnormal substrates in the maternal circulation. And it's usually maternal, not fetal, because with fetal metabolic disorders, they don't really play a role in intrauterine life. They become operative following live birth. And by metabolic, I could mean, for example, unregulated maternal diabetes, so diabetic ketoacidosis. I could mean hyperthyroidism or hypothyroidism. That's the least common of the mechanisms of stress. And mechanical stress doesn't really occur in the setting of pregnancy, because mechanical stress that might have an effect tends to be in the catastrophic realm, like I suggested with the motor vehicle accident and the complete placental abruption, which is why I have a strike through there. Some caveats: meconium is not always passed, even in circumstances of acute, subacute, or prolonged intrauterine stress. When I say acute, I mean hours. Subacute in my mind is days, chronic is weeks in the general sense. So catastrophic is minutes in this schema that I'm presenting you. NRBCs may not be present in acute catastrophic hypoxic events, and meconium and or NRBCs cannot time injury, nor can any process that's reflected in the placenta in terms of its own chronicity be used to time injury. Now, there are exceptions to that, but I'll leave that statement at that for the moment. So that they reflect intrauterine stress, but they don't time when some point of no return came and the fetus and or neonate will suffer some permanent deficit. So placental markers, I'll begin with nucleated red blood cells. And as I said, the number of NRBCs in any cross-sectional area of the fetal circulation in the placenta or in a newborn CBC reflects both the duration of the stressor, the nature of the stressor too, given that hypoxia, as I said, is a more robust stimulus, and its intensity. And that in a very general hand-waving way, the postnatal decline of NRBCs roughly mirrors the antenatal onset. So that, for example, if you were to have chronic fetal maternal hemorrhage and the NRBCs were markedly elevated at delivery in a fetus that was born alive, a neonate with a hematocrit of 11 or 15%, those NRBCs would not disappear within 24 hours. They would take a very long time to subside, in part because you've probably got erythroblastosis, but also in part because the chronicity of the stimulus is such that it takes time to abate. And now I want to talk for a little bit about relative versus absolute nucleated red blood cells. Most hospital laboratories will report out an NRBC level, if they report that out, on a complete blood count as a relative number. So many NRBCs per 100 white blood cells. So let's take a value of 8 NRBCs per 100 white blood cells. That would mean that on the left-hand side, if you have a gallon bucket And you have my red ball that's represented by NRBCs and the blue balls that are represented by white blood cells. In this diagram, the NRBC to white blood cell ratio is 1 to 10. So there's one NRBC for every 10 white blood cells, or it's 10% on a lab automated printout. However, if you take that same gallon-sized bucket and you double the number of ping pong balls in there so that you now have 2 red ping pong balls, but 20 blue ping pong balls. And again, the red ping pong balls are NRBCs and the blue ones are white blood cells. The relative ratio is still 1 to 10. There are 2 reds for every 20 blues. However, the absolute difference between the buckets is twofold. There are twice as many nucleated reds in the second bucket as the first. The reason I mention this is because the relative value of NRBCs per 100 white blood cells on an absolute scale, that is in a volume of blood, is modified by the denominator, the white blood cell count. So if your white blood cell count is higher, even at a ratio of 1 to 10, your NRBC count is also going to be higher because of the absolute or total number of NRBCs and white blood cells in that same volume gallon bucket. Hopefully that makes sense. If not, please ask me at the end of the talk. And the reason I mention this is because an absolute NRBC level sometimes provides very different information from a relative NRBC value, so that the former may look fairly innocuous in terms of being modestly elevated. But in fact, if you do the absolute count, it may reflect a longer duration of NRBC release. So here is what nucleated red blood cells look like in a small stem vessel. They are, as I'm sure everyone knows, the same size as a mature or anucleate red blood cell, but retain the nucleus. So that you see in the white circles, there is the dark, pitch black, really, hyperchromatic, very round nucleus of a nucleated red blood cell. And nucleated red blood cells, I'll just digress for a second, are, as we know, formed in the fetal liver and blood and bone marrow, and are released preformed from those sources, from those reservoirs. And so the first NRBCs that are going to be released look like mature nucleated reds. They are at their final nucleated form, same size as I said, and of course the cytoplasm is the same tincture as the anucleate red blood cells. Whereas with increasing time, there can be what I call an NRBC left shift, but you will get an increasing number of less mature nucleated reds, so that I have the arrows on relatively mature ones, but there are some other cells here in the background that are going to be less mature nucleated reds that are less obvious as NRBC precursors, and yet they are, given a chronicity of a stimulus. And let's say this is long-standing, poorly controlled maternal hypertension, where fetus might be hypoxic for some period of time, or days or weeks. When it comes to meconium, as we know, the gross color reflects the duration between the meconium discharge and delivery, and microscopically, the depth of meconium uptake, whether it's into the umbilical cord or the fetal surface of the placenta, the chorionic plate, the depth reflects the duration between the meconium discharge and placental delivery, which is usually the same time in essence as fetal or neonatal delivery. The density, however, at any one plane reflects the thickness of the meconium, that is the density of meconium, and therefore is in its own way a surrogate for meconium intensity. However, I stress to all of the trainees that I teach that I require two-factor authentication of meconium, because there are many reasons you can have brown pigmented macrophages in the extraplacental membranes or the chorionic plate, not so much in the umbilical cord, and that for me to ascribe that to meconium, not only does the brown tincture have to look like kind of the correct hue and quality, but it has to be matched by some other known identifier of meconium, either clinical history of meconium discharge, obvious gross meconium placental discoloration, again with a caveat that sometimes you have to distinguish that from, let's say, acute chorioamnionitis or old blood breakdown products, or particulate meconium, because even though brown meconium macrophages can be due to a number of reasons, there's only, particulate meconium only looks like particulate meconium, and I'll show you a few photos. So here's fresh meconium discharge in a placenta. This also happens to be a stillbirth placenta, and hopefully that is visible to those of you who spend any time evaluating stillbirth placentas and fetuses because of the ruddy brown discoloration of the umbilical cord. That is due to blood breakdown pigment, and it's just a nondescript stillbirth change that occurs. However, you can see on the opaque surface, on the opaque fetal surface, that there is a green discoloration to some material that's been deposited on top. That's relatively fresh meconium. In contrast, this is older meconium discharge, again in a stillbirth, and this imparts a more brown or sometimes yellow hue. This could be intense acute chorioamnionitis rather than, for example, older meconium. So again, it requires correlation with a known meconium discharge by virtue of other information in the patient's clinical history. Or other means of evaluation of either the fetus and or placenta. Particulate meconium looks like particulate meconium. It is brown, light brown, and globular. Sometimes it's particulate, but it has an amorphous quality to it, as it does when it's admixed with other particles. So as some people, some of you may have noticed by now that when you prepare a membrane roll from the extraplacental membranes, whatever materials, particulates were on top of the membrane roll are going to get caught up in between those layers of membrane roll. And this is an example of some, it looks like mostly red blood, or blood, I should say, red cells, and then some other nucleated cells, plus a few fetal squames, and then particulate meconium that is admixed. Again, it has that same kind of light brown amorphous quality. When it comes to being taken up into the stroma, of course, it is first visible in the amnion stroma of the extraplacental membranes, even before it's visible in the superficial stroma of the chorionic plate, and penetrance into the umbilical cord or Wharton's jelly is probably takes the longest period of time. But it has this light brown discoloration. And in this particular view, I would say that the number of meconium macrophages I can see, and I can see probably about 10, 6, 8, 10 of them in this field, is a suggestion to me on this one relative horizontal plane that there may have been relatively thick meconium prior to delivery. Here's meconium that is deeper into the extraplacental decidua, and you will notice that the cytoplasm of the macrophages has this bubbly or frothy appearance, and that's because this is relatively more remotely discharged meconium that has since been taken up into the lysosomes and imparts this kind of bubbly uptake. My counterpart, Drusilla Roberts at MGH, first pointed this out to me some number of years ago. So not only can one assess some measure of chronicity because of the depth of the meconium, so it's gone in this case through the extraplacental membrane stroma, through the chorion epithelium and into the decidua, but it also has this frothy lysosomal quality to its visual aspect. I want to say a couple of comments about meconium myonecrosis. This is a very uncommon, very catastrophic observation when it is present. And it is defined as the pycnosis of umbilical and or chorionic myocytes. And because they're myocytes in those areas, they have to obviously be fetal in origin. So it's the umbilical vessels and or their branches on the chorionic surface, the chorionic vessels. And it's due to chemical necrosis from bile acids. So it's a chemonecrosis mechanism. And it is always the result of prolonged meconium discharge, because the meconium needs to have been passed for a long enough interval between the onset of the discharge and delivery to be taken up deeply enough into the umbilical cord to hit the umbilical vessel walls and or the chorionic plate to come into contact with the chorionic plate muscular walls. And the effect of meconium myonecrosis is compound. First of all, you have whatever stressor or stressors elicited the meconium release in the first place. Secondly, you have alteration in vascular tone once meconium myonecrosis occurs, so that the normal pulsatile movement of fetal blood from placenta through the cord to fetus and back again is interrupted. So it's a two-hit phenomenon, which is in part why meconium myonecrosis is such a devastating microscopic feature to witness. And in all the years that I've seen meconium myonecrosis, I would have until recently said I have never seen it associated with a newborn that went on to be discharged from the newborn nursery in a normal amount of time with normal newborn parameters. But I just saw that about 2 weeks before I left for my current place on the vineyard. I left Houston for Martha's Vineyard. And Drusilla Roberts, again, has said that in her experience, at least the last time we talked about this, that she had also seen 1 or 2 cases where the baby appeared to do fine, but all the rest of the cases I've ever seen are associated either with stillbirths or live births with permanent morbidity, usually having some form of neurodisability. And the pattern of meconium myonecrosis, because it's a consequence of direct meconium passage in macrophages through umbilical cord or chorionic stroma, the area of meconium myonecrosis that is first visible is the area of the umbilical or chorionic vessel that is closest to the amniotic fluid, so the outer walls of those vessels. Again, those closest to the amniotic fluid, as I've highlighted with these yellow crescents. And you often see, but not always, in the umbilical cord, admixed meconium macrophages. And in part, it's because, for reasons that I don't understand, meconium is harder to see in umbilical cord stroma than it is in the extraplacental membranes or the chorionic plate. That's it in part, and sometimes it's because it's just not in whatever is your plane of section. And it can also elicit a chemotactic fetal vasculitis. Now, there's controversy about this in the literature, but there's enough evidence, including my own observations, that I do believe that, in fact, this is true. And it can impart a fetal vasculitis. And if so, it tends to be out of proportion to meconium inflammation, that is acute subchorionitis. So that it tends to be directed more toward the fetal blood. And again, that's, I think, because of the proximity of fetal blood to the vessel wall. And the associations with untoward fetal and neonatal outcome, as I've said, include stillbirth and neurodisability. Here is a medium power image of meconium myonecrosis. And so in this image, the umbilical cord, the outer edge of the umbilical cord would have been to the lower right of the frame. So that is on your, from my about 2 o'clock down to 7 o'clock, the rounded pycnotic myocytes represent meconium myonecrosis. And when you are at low power scanning an umbilical cord, this is not obvious unless you are heightened to look for it. It is one of those pathologic processes that, although it is imparts very serious connotations, is not in your face or very dramatic visually until you know to recognize it. Here's another view of meconium myonecrosis, a little closer up, and in this slide, it's present in association with fetal vasculitis, as I mentioned, umbilical vasculitis. The myocytes again become rounded and discohesive, and the nuclei become very pycnotic. And in this even closer power view, one can sometimes see loss of nuclear basophilia of the myocyte, as I'm showing with this arrow, and is probably present in other myocytes, although it's hard to know if you're just not quite in the plane of the section of the nucleus. But the affected vessels become, again, round with pycnotic and misshapen nuclei. And in this last image of Meconium myonecrosis, I have an arrow pointing to one of these lysosomal rich Meconium macrophages that has come to abut the outer umbilical vessel wall. So in fact, the oval image just down to 5 o'clock is Meconium is a myocyte, an umbilical myocyte that has undergone Meconium myonecrosis. And again, I'll point out to you the pycnotic irregular nuclei, some of which are exhibiting early cytolysis. What are the mechanisms of potential injury in the setting of Meconium myonecrosis? As I already said, it's the alteration of fetal placental vascular tone. It probably has something to do with cytokines elicited in the context of meconium-induced vasculitis. It's the superimposed effect on whatever already is the very stressful primary process or processes that elicit the meconium discharge in the first place. And very rarely you can get meconium-induced umbilical cord ulceration with vessel rupture. I have seen this spontaneously less than 5 times in 30,000 placentas in my years of looking at them. What are some correlations with when one has an autopsy that goes along with a placenta, whether it's a fetal autopsy or a neonatal autopsy? With chronic meconium discharge, or I should say not chronic, but prolonged meconium discharge, there can be meconium aspiration, meconium ingestion, and meconium pneumonitis. So again, that's a chemopneumonitis. It's not an infectious pneumonitis. So as we all know, fetuses begin to breathe in and swallow amniotic fluid starting in the 2nd trimester of pregnancy, and therefore they're going to breathe in and swallow whatever's in the amniotic fluid, whether it's neutrophils from ascending infection or bacteria from ascending infection or meconium that's been discharged into the amniotic fluid. The nucleated red cell correlates of more prolonged discharge prior to delivery include a left shift both of the NRBCs, so that they're more primitive precursors are elicited, but also in the setting of infection with NRBC release, you see left shift of the myeloid series. So you get a white blood cell left shift as well. In prolonged mechanisms of intrauterine hypoxia, but that are compatible with fetal survival, like chronic fetal maternal hemorrhage or chronic hemolytic anemia. One can see erythroblastosis, but again, think about it. This requires that not only must the hypoxic mechanism be prolonged, but it has to fall short of intrauterine demise for the fetus to first not only release all of its NRBCs, but then begin accelerating production of nucleated reds in the form of erythroblastosis and releasing those into the circulation. And if there is an autopsy to go along with a placenta in a case of prolonged NRBC release, you can see extramedullary hematopoiesis in more than just the liver. It can occur in a variety of organs. I've seen it in the thymus, I've seen it in the pancreas. I perhaps have seen it in the spleen. So one can get extramedullary, extrahepatic hematopoiesis. Here is an example of an autopsy from a case with prolonged meconium discharge prior to delivery, and the infant died very quickly following delivery. If you have a fetus or a neonate where you are not granted internal evaluation, but you can do an external exam, you can open the mouth to see if there is meconium staining of the tongue, as I'm showing you here, the right side of the tongue, so the anterior portion of the tongue. So even if you don't have other information by being able to look internally at organs, you can still recognize meconium ingestion. If, however, you do have the the ability to look at organs internally, both grossly and microscopically. There may be meconium that has been swallowed and reached the level of the stomach. And yes, the intestines create meconium, but of course it's only the large intestine. So under normal circumstances, one would never see meconium in the mouth, in the esophagus, or in the stomach. Right, so this is prolonged meconium discharge. And here is an example of intense meconium aspiration. Again, I'll point out to you that the meconium is amorphous and varies from being globular to generally particulate without any particular shapes. And in this case, the meconium in the fetal, what would be the neonatal airways, are admixed with a number of squames, suggesting to me parenthetically that there may have been oligohydramnios in this case. But again, that's a soft suggestion. By one microscopic observation, you would need other information. So meconium aspiration. What are some of the autopsy correlates that if one is permitted to do an autopsy in the setting of fetal or neonatal demise, can be additional markers of the extent and intensity of antemortem stress? And I've listed a few. These are the ones that for me are the most commonly present and easiest to evaluate, but there are others. There's hepatic changes, and anyway, there are other features that one can see in autopsy pathology that reflect stress prior to demise. For example, petechial hemorrhages in the thorax, so on the thymus, lungs, heart. But with thymic involution, with an acute phase reaction, there is a starry sky cortical change. Why does that happen? It's because with acute intrauterine stress, fetuses release adrenal hormones, and those hormones are toxic to the thymocytes, the thymic thymocytes. And so the thymocytes undergo apoptosis, and the resident macrophages gobble up the debris, much like one would see a starry sky pattern in Burkitt lymphoma. The subacute pattern reflects volume loss of the thymic cortex. So you get cortical thinning and a relative greater visibility of the medulla and the interlobular stroma, right in between the thymic lobules. And chronic thymic atrophy, I put in brackets because we don't see that in intrauterine processes. Fetuses I shouldn't say we don't see that. I rarely see features of chronic intrauterine stress because, again, fetuses don't survive, but that is just frank thymic atrophy where you end up getting a reduction in thymic weight, in addition to a virtual loss of the medulla of the cortex entirely, so that only the medulla remains. And with progressive lengthening of thymic stress in involutional changes prior to delivery, the Hassel's corpuscles not only become more prominent, but you get this central cystification and sometimes calcification. With adrenal changes, acute adrenal changes are corticolysis of the definitive fetal cortex, so that the subcapsular, not fetal, the definitive cortex of the adrenal gland, so the subcapsular cortex. You undergo this corticolysis that is a cystification that I'll show you by virtue of an image in just a second. Subacute changes are the accumulation of lipid in the fetal cortical adrenal, the fetal cortical cells of the adrenal gland. And again, chronic changes, which one rarely sees in the setting of intrauterine stressors, are ablation of the medulla entirely. And so I put them into brackets because the few photos that I have of these last processes, which I won't show, are actually from infants, from neonates or infants. So here's acute thymic apoptosis, so acute thymic involution. This is the thymic cortex. You can see the interlobular septa, but the what I have circled in black are macrophages that have ingested apoptotic thymocytes. So I see I have 3 circles in this image and a couple of macrophages in 2 of the circles and at least 1 in the other. Here is subacute thymic involution, where there's volume depletion of the cortex so that the medulla is relatively more prominent. At term, the thymic cortex should be visually about 2/3 to 3/4 of a cross-sectional area of the thymus. And so in this view, for example, I would say that the thymus occupies about the medulla occupies about 50% of the visible view, because there's also some medulla on the upper right. And in addition to volume depletion of the thymic cortex, there's cystification of Hassel's corpuscles, and because this is ongoing stress, you still see the acute changes of the cortical starry sky pattern. With the adrenal gland, I couldn't find acute corticolysis in my files, I guess because it's common enough that I haven't saved one of these slides for quite a long time. But what I've done is to create a white circle in the subcapsular adrenal area to show you that it would be a clearing out of these adrenal definitive cortical gland cells to have the appearance of a microcyst. And with subacute adrenal involution, there are a lot of white-looking fetal cortical cells, but I'm not talking about all of them, just within the circles, the cells that have very round lipid uptake. And this has to do with alteration of hormone, cortical hormonal metabolism, so that you end up accumulating lipid, and the exact pathway is beyond me to recite in this moment, although I did know it for about 5 seconds a long time ago. So at any rate, you get this lipidization of the fetal cortex in subacute adrenal involution. A couple of more final things to say about thinking about intrauterine stressors that lead to meconium and/or NRBC discharge. Again, stress is not equivalent to injury. This is a very important topic when it comes to the medical legal arena, because I can talk about mechanisms of intrauterine stress, their timing, and some element of intensity, but I cannot know at what point in time a stressor that's reflected in the placenta may have contributed to or caused an ultimate outcome. So the analogy I give is a twig on the ground, that if I pick up a straight twig and I bend it, hold it in between my fingers, two fingers on each end, and bend it, I am imparting my own torsional strength stressor on that twig so that it bends from its normally straight equilibrium shape. But if I let go of one end of the twig, it will snap back into being its at rest straight form. However, if I take that same twig and continue bending it, at some point my strength will outweigh the intrinsic strength of the twig, and I will break the twig. When it comes to thinking about the placenta, there is no magic change that occurs in these processes that ultimately lead to injury, so that you can say, aha, at this point in time, there was no injury, but this many minutes or hours or days later, the injury had occurred. So that injury, except for rare circumstances, cannot be timed from placental evaluation. And the exceptions are the two bookends of the spectrum of intrauterine stressors and outcome. One is the example I gave you, an acute catastrophic event where the moment of the catastrophe is known in time, and you know the outcome, which is rapid fetal demise. So you can infer that the onset of the stressor is, in essence, the same as what's going to be the onset of the rapid fatality. So that timing is known when it comes to timing injury, because from the moment of inception, the outcome was a given. The other exception is the other end of the spectrum, where there is a silent stillbirth without overlying circumstances of the intrapartum. So that a mom comes in and says, I haven't felt the baby move for a few days, and there's a fetal demise, and when the baby is delivered and the placenta is delivered, one can tell from the process that is reflected in the placenta what the likely or certain mechanism that led to stillbirth was. Again, because there are no overlying events of, and I'm using the intrapartum, that could potentiate or independently lead to intrauterine, an untoward intrauterine environment. I've given you some selected references, all of which come from, I think they're probably all chapters or books that I've either edited or chapters I've written. But within these chapters, which were published relatively recently, they all came out in, I think, 2018, I have a number of citations that reflect some of the reading that I had done in preparation for these chapters. And so I've listed some here. I do think I'm just about on time, and this is a picture of my current crew minus our newest faculty member who just started yesterday. This is the Texas Children's Hospital Department of Pathology, and these are the faculty in all of the various areas of specialty and subspecialty, and they include PAs who begin as instructors at Baylor College of Medicine, PhDs, MDs, MD PhDs, DOs, the gamut, but this is us. And those of us at the top are either our chairman, Dr. Jim Versalovic on the left, or we, the others, are division chiefs. And that is all I have. And I am available for questions. So let me see if I can figure out how to turn my my camera back on. Let's see. There we go. Start video. Here we go.
Thank you so much, Dr. Boyd, for this excellent talk. And I'm sure the audience enjoyed it. So before I go for the Q&A, I wanted to share my screen quickly, just to, so if you can see the screen, so you can see that how to get the CME credit for this lecture. And as you know, that City of Hope has accredited this talk for 1 CME credit. So the first thing, as I have mentioned before, is that you have to register to the City of Hope CME site. So please register there. And then after registering, if you are watching this lecture from the United States, you can text the code to this phone number here. And if you are watching it from outside of the United States, you can email the code to this email address. And please make sure that the attendance is recorded only during the live lecture, and the code will expire after the live talk is over. And once you send the code, so you will get a evaluation form from City of Hope. So please submit your feedback and evaluation within 1 business day. So that's all about the how to get the CME code. And I already shared the CME code on the chat box, so you can look at the chat box to have a look at the CME code. And I will quickly see what questions are there for you, Dr. Boyd. So one question that I saw is one of the viewer is asking that you mentioned about medical legal scenarios. So can you give one random example of what medical legal scenario can arise from these situations?
There are so many. Let me see. And I should say there are so many, and the placental processes that are reflected in medical legal cases are the same ones that occur in the hospital setting that lead to poor outcomes. And so high-grade fetal vascular malperfusion is one of the frequent flyers. Advanced amniotic fluid infection is another one of the common ones. Maternal vascular malperfusion, believe it or not, is often a backdrop. In most developed areas of the world, pregnancies are monitored so that fetuses that are falling off the growth curve because of maternal malperfusion, i.e. hypertensive type disorders that are either not well controlled or not controllable, pregnancy is interrupted by iatrogenic delivery if there is a danger to the fetus. And so maternal vascular malperfusion is rarely in the medical legal setting a common, a principal player in terms of processes reflected in the placenta that can be associated with poor outcome, but it is not infrequently a backdrop. There are other processes that also are pretty frequent backdrop flyers, but then I don't want to get in too much into the clinical realm. But to give you a discrete example, mom is decided that she wants to deliver at home. and it's a home birth, and it's being attended by a midwife, or not a midwife, but it's just a home birth with friends or family members. And the delivery is prolonged. Mom's membranes are ruptured for a few days, and eventually there is something that alerts either a family member, family member, or the clinical caregiver, like a midwife, that the fetus may be in distress or is in distress, and mom is transferred to a hospital for expedited delivery. And the fetus is born, and let's say it's born, but with poor APGAR scores that never recover, and the neonate goes on to have developmental delays throughout childhood. Placental evaluation reveals that there's amniotic fluid infection, i.e. an advanced pattern of acute chorioamnionitis that contains not only necrotizing chorioamnionitis, that is the maternal inflammation response, but also intense fetal vasculitis, confluent neutrophils that are traversing through all three umbilical cord walls and out into Wharton's jelly, that is perivasculitis. And in addition to that, there is prolonged meconium discharge with meconium myonecrosis. So that you have let's say bifecta, the advanced chorioamnionitis and also the meconium myonecrosis to overlay that. And so the question would become, at what point, or a question in terms of standard of care, again, which fortunately as a pathologist, I don't address, but a question would be, at what point ought this child, or could this baby have been delivered earlier than it was to effect a different outcome? So that's one example. Another example would be that it's the entire intrapartum process occurs within the hospital, but that there is an episode where there's uterine hypertonicity or hyperstimulation, so that there are contractions that are too intense and too frequent. And there is also, when the placenta is delivered, an acute chorioamnionitis that is, let's say, of a lesser degree than the situation I just described, where you have a solid acute chorioamnionitis, but perhaps a more modest fetal vasculitis, so that it's not intense and confluent involving all three umbilical vessels. Well, at what part does the amniotic fluid infection play in the neonatal presentation, and what part of it might have been hypoxia-derived uterine hyperstimulation, where there are no placental footprints? So there's no way for me as a pathologist to assess what kind of effect that alleged hyperstimulation may have caused on the fetus. So that's another example where there's an interplay of a background intrauterine process, but the overlay of intrapartum events. I hope that I explained it well enough with those two examples. Any other questions?
Yes, Dr. Boyd. So there is another question from one of our viewers. I hope I got the question right. So this is, it's about how to make an assessment on macerated fetus.
I think the question would have to be better defined about what kind of assessment.
Right, because the question is in another language, and I just used a Facebook translator. No, I don't have a better version of the question yet.
That's fine. So I can attempt to address that in some ways. I don't know that this is really the intent of the question. So with fetal maceration, if one question becomes how long had the fetus been dead in utero prior to delivery, that the best gauge, one of the best gauges of assessing gestational age is foot length, because it's more impervious to changes in body fluid, such as hydrops or extensive desiccation, right? Extensive loss of bodily fluid with prolonged in utero retention following demise. So that's one answer I can give you. However, the caveat with that is you have to make sure that there isn't a background of either intrauterine growth restriction or fetal macrocephaly, right? So that you have a baby that's born to a gestational diabetic, and the baby had been measuring large for dates, or the uterine fundus large for dates throughout pregnancy, or the fetus was a fetus that was being delivered of a mom who was known to be a long-term hypertensive. So in those instances, you have to modify foot length with factors that might have modified the intrinsic fetal size prior to demise. Another question that I can answer pretty readily is that, and it's something that I've seen trainees confuse a lot, and even sometimes practicing pathologists, that if you have a stillborn fetus, that it really truly is stillborn, no signs of life, and no attempt at resuscitation, if you take cultures and you do a spleen culture because you can't get fetal blood, spleen is a great substitute for fetal blood. If you are taking your splenic culture sterilely and it comes back with a known enteropathic organism like E. coli, and you have chorioamnionitis in the placenta, and you have, let's say, a lung culture where you also have E. coli, the fetal environment in utero is a sterile environment. There should never be bacteria that gain access to the fetal body, no matter how prolonged the demise to delivery interval is. Whereas, as we know, with humans who are born and then go on to die, there may be postmortem intestinal seepage or lack of sterility or any number of things that could give you a false positive culture result. But fetuses live in a sterile intrauterine environment, and cultures that are positive, especially in the face of other corroborative information like chorioamnionitis, should be assumed to be accurate, not post-mortem artifact, unless you have strong information to the contrary. So if it's 3 or 4 different organisms you're culturing from the spleen and none of them are known to be intrauterine pathogens, well then that's post-mortem contamination. Having not post-mortem from the fetal body, but from the process of manipulating the fetal body and taking the cultures. Other questions?
Yeah, there is another question. It's about did you have any observations which is somewhat related to COVID infection in the mother?
I think the COVID literature is pretty well exhausted by now. And so I would say that I don't have, in the context of this lecture, anything that's really that valuable to add. Our observations at Texas Children's Hospital, because I've been practicing for most of my pandemic experience there, are that indeed we have had fetal demises in the setting of maternal COVID disease, whether it's pneumonia or some other form of morbidity, and that the characteristic COVID placenta changes are present. But I don't know quite how to talk about NRBCs and meconium in that context. So I'm not quite sure how to better answer the question.
Right, I see that. I think, Dr. Boyd, these are the questions that I found online from our viewers. And I wanted to let you know that you would be happy to learn that we had more than 100 viewers who joined from different countries across the world. And I could keep track of some of our viewers who joined from Myanmar, Mexico, India, Nigeria, Tanzania, Serbia, some of the names that I could keep track from the viewers. And thanks to our viewers for joining us. And if you like our Pathcast lectures, so please don't forget to subscribe to our YouTube channel, that is Pathcast. And we also have a Facebook page. You can follow the Facebook page as well. And on our website, that is pathologycast.com. So the lectures are organized by subspecialty, so you can access those lectures there. And we have our next lecture coming up, which would be on September 6th. And that would be a talk on liver pathology, which would be delivered by Dr. Shefali Chopra from University of Southern California. And the topic will be on well-differentiated hepatocellular lesions, and hope to see you at that time. And thank you again, Dr. Boyd, for this wonderful talk. Thanks a lot.
Thank you for inviting me, and thank you all for your time.
Thank you.